Hi everyone, I'm Jennifer McQuaid, class of 1993, and I'm introducing the panel Women's Health from Periods to Pregnancy to Perimenopause and Beyond. As the afternoon rolls on, I'd like to invite us all to take a pause for just a moment and take a deep breath and to feel the power of this Williams Women's Network that we're all a part of. This weekend is an invitation to us all to be a part of it because it is here for us to lean on. So when the committee asked if I would introduce this panel, I jumped right in because as you can guess by my class year, 1993, I myself am in the middle of all these life changes. But more importantly, because in my own work as a clinical psychologist, I regularly see the power of sharing scientific findings in the form of both information and options. Information provides context and understanding, and options provide hope. When women have access to accurate information about their health and the choices available to them, they can more confidently and capably ride out the transitions and the challenges before them. And they can steer their own course towards greater well-being. I also have the honor of introducing this panel as a proud member of the We Lead Advisory Board. As you've heard multiple times already, We Lead is a really important women's philanthropy initiative where we're focusing on closing the gender gap in leadership giving. We Lead seeks to increase the number of alumni gifts that people make at the level of 2,500 or more in order to close that gap. At some point this weekend, please feel free to speak to me about this if you'd like, or another member of the board. And now I will turn over the floor to our speakers, Nina Kozlov, class of 93, Nisha David, class of 05, Elizabeth Curtis, class of 17, and who do you have with you?
Josephine, class of.
Awesome. And moderator, public health lecturer, Marian Min Barron. Thank you.
Great. Is this good? Oh, this is loud. Hi, everyone. Thank you, Jen. Welcome to the afternoon panel session. How are we doing today? Oh, double thumbs up? Nice. Awesome. So we all come to this space with some shared identities, being women or menstruating. But we also have really individual lived experiences, and I imagine that your curiosity and your camaraderie has bringing you into this space. So just to get us started, and there's no pressure truly, we thought we'd just ask a show of hands for a couple of questions. Are we game? Okay, awesome. So, who gets periods? Okay. Who doesn't get periods? Who knows when to expect their next period? Okay. And who doesn't know when it's going to come? Who is happy with how their periods are doing? Oh, all right, I like it, yeah. And who's not so happy with how their periods are doing? All right, yep, that's a +1 with me. Who would say that their periods are normal? Normal, okay. And who would say their periods are not normal or maybe wondering if their periods aren't normal? Mm-hmm. How many of us feel comfortable talking about our periods with our providers? Awesome. How many of us feel like we know what to expect with our periods? Who is premenopausal in the room? Who is perimenopausal? Who is postmenopausal? Awesome. Thank you for engaging and participating. These hands are showing us who's in the room, but also maybe showing us what we already maybe feel that these topics have been stigmatized and maybe a little hush-hush in the past. But, this is a space and a weekend and, like a panel, we're really just trying to bring topics and conversations into the light, really. And so that's why we've brought these amazing, badass people to the stage. So I'm wondering if maybe each of you could start off and just share a little about your background and maybe the perspective that you will be bringing to this talk.
It's on? Oh, great. Hi, everyone. My name is Elizabeth. I use she, her pronouns, and I am a reproductive health nurse working at Planned Parenthood doing post-abortion care and at the hospital doing postpartum care. I'm studying to be, thank you. I'm studying to be a nurse midwife at Yale School of Nursing, and in the theme of sharing our cycle status, I am currently not menstruating because I am 10 weeks postpartum tomorrow and exclusively breastfeeding. Thank you. So I don't know when my period's going to come next. Yeah.
All right. This is loud. Okay. So I'm Nisha David, class of 05, and I'm an OBGYN. I practice in Cape Cod, Massachusetts. And let's see. So my goal today is to also talk to you guys about, some of the thoughts about how to control your periods, how you may or may not be happy with them, and what you can do about them. And so I don't have a whole lot to prepare to tell you about those things. I think a lot of it's going to be from question and answers of what you guys want to know about, just because it's a very broad topic. And then in the spirit of sharing about our menstrual cycles, I choose not to get a period. I identify as non-binary, and I don't like getting a period. And that works for me. So I use an IUD, and I don't get them.
Hi, I'm Nina Kozlov, class of 93. And I am a non-clinician. I'm the only non-clinician up here. But based on my own experience, starting about 8 or 9 years ago, so I'm 52, and this was at about 43, 44, I was drawn into what's now become a very long passion project to learn more about perimenopause. And that led me to education through a website I started called womenlivingbetter.org. And what I came to realize was what's really missing from the story is research. There is an unbelievable gap in midlife women's health research and just what our bodies do normally. And so now I have found 2 amazing collaborators, and I'm doing research. So I can say more about that later. And while I will tell you that I've come to learn that I've been, I think, and this is what my research focuses on, in perimenopause for 8 or 9 years, officially it was just last year, and we could talk more about why the definitions don't really serve us, the current definitions. So.
Awesome, thank you. So there is like a lifespan here, and I feel like we could talk about so many different things, but I thought maybe what would be helpful just to start us off is if each of you could maybe share. There's so much information out there, right? Like from the media, from our provider, intergenerationally. Maybe you could share if there was like some key points that you wanted to give all of us. And we also, as a panel, we've really discussed that we're also interested in to know what you want to know, right? So we're really dedicated to leaving time for some Q&A as well. So.
Well, I can start as we keep going down this this line. But my real focus, I think, when we all got to talk, and me get so excited over hearing them talk about their work because they're just the coolest people. My niche is that I love tracking my periods. And the fact that I don't have my period right now is very sad to me. Actually, it became kind of a pandemic project for me. I had an IUD, but I decided to take it out because I wanted to be in touch with what was happening in my cycle. So there's this idea of periods as the 5th vital sign that we should be tracking. And that is talking about bleeding. That's talking about how regular your periods are, how many days they last. And that can be a good data point. But there's a lot more there about your temperature changing throughout your cycle, your cervical mucus changing throughout your cycle. So a pandemic project for me was sourdough starters and tracking my cycle. Oh yeah, share pics. Mine has died long ago, actually. But there are so many different ways that people talk about tracking their cycles, and this has been as old as time. So you could just literally look at the days when your period comes, count out to estimate when ovulation is going to be. You can track your temperature and see when ovulation is going to happen, check your pattern. There's a big reliance now on apps. I don't know how many people here, if they menstruate, use apps to track their cycles. But there are great ones that tell you roughly when they would assume you're ovulating based on your menstruation. There are other ones like Natural Cycles. I don't know if anyone got a million targeted ads for that before they signed up for it during the pandemic like I did, where you take your temperature every day and plug it in, and it will tell you if you're having a green day, so you're around ovulation time, if you're trying to get pregnant, or a red day, you're not around ovulation time, you likely won't get pregnant. Very cool science that's out there now that we're putting into people's hands. I just had a fun story to share about tracking your cycle versus knowing your own body and kind of being in touch with what's going on, and that I was using Natural Cycles as a birth control method when I conceived Miss Josephine up there. And I really, really do believe in fertility awareness method as a great method of birth control and knowing your cycle and your ovulation. But I was in the middle of nursing school and so stressed. And my cycle changed a lot based on my stress. And that was not necessarily the length of my cycle, but the length of my luteal phase, so the time between my ovulation and when my next period started, which is a whole different topic I won't go into right now. And my ovulation date changed when I got more stressed throughout different points of my cycle and I wasn't as regular. And so I had a green day, meaning because I was using it as birth control, I was okay to have sex and I wouldn't get pregnant. But if I were paying attention to my cervical mucus and all these things, I was absolutely ovulating and was just ignoring it. So we're very happy that Josephine is here as a result of that. And I will totally go back to like tracking my cycle and things like that later. But a fun data point that I think is important to share. I'm gonna cut it there for now just because I want you all to talk, but so excited to talk about more.
All right, thank you. So in the same vein of talking about birth control and contraception, right? So I mean, in my work, I take care of pretty much everyone, all ages that are female, right? So, you know, I do a lot of pregnancy and postpartum and menopause and all these other things, and just people who just want to not get pregnant, right? But what I thought would be an interesting talk for now is to talk about ways that you can use traditional like birth control methods, not just for contraception, just because there's a lot that you can do, and I think that that's something that a lot of people don't know a lot about, and I think it's something that people should know as an option, right? So basically, there's a lot of ways that you can control your cycle, right? So, for example, for me, I'm just going to use me as an example. I, in the past, used to have very, very heavy cycles, and I had to tailor my work around it, or, you know, activities and sports and things like that. And I didn't know at the time, even throughout all of Williams, that you could do something about that because it just wasn't really talked about, wasn't really taught. And so it wasn't until I was in med school that I even heard about what an IUD was. And I was like, oh, what's that? That's a thing? Okay, I want that. And so so there's kind of two main categories of when I talk to patients about how to control their cycles. Some people do better with having a type of birth control that is systemic, that goes throughout their whole body, that can take care of kind of everything that's also related to ovulation, right? So some people, you know, every month have either heavy periods, painful periods, but some people also get these cyclic symptoms, right, that are harder to define. So they can have mood changes. I get people who are very depressed before their periods, very anxious around their period times. Maybe they have migraines that come with their periods. There's all these different things that people have. I have patients who have a strong neurologic history who get seizures around the time of their periods. And so some of these people who have these systemic symptoms, that it's not just about bleeding, do much better to have systemic birth control, right? So it's either a pill, you can do a patch, you can do, you know, a number of like depot shots, there's an implant in the arm, and those help to regulate all of those things, right? So normally throughout the month, your period cycles and your hormones go up and down throughout the month. So some people, yes, yeah. She has a very, very cool tattoo that demonstrates the menstrual cycle. Yes. and the hormone fluctuation during it, right? So for some people, that is excellent. And some people, wreaks havoc on them. And so for the people who it really messes with them, trying to catch up with what their hormones are doing throughout every month, and every month they feel like they're trying to reset their body and get back to normal, getting on a birth control pill, for example, and having the same hormones every single day is like such a breath of fresh air, right? So they know what to expect. They can then figure out if there's other things causing their migraines or other things causing their mood change or whatnot. And it levels the playing field so that they can function. There are other people who just want to stop their period or just want to not have it be so heavy or don't want the rest of the hormonal change on their emotions and whatnot and just want it for birth control. And so for those people, they do much better having local methods like an IUD or, for people who just want to stop their periods, an ablation, like a surgical procedure to burn the lining of the uterus and slow down their bleeding, or hysterectomy, or all these other options. So a lot of, and I'll cut it short so that we have time for questions at the end, but a lot of what I do is, helping people identify what is working for them with their periods, what is not, and not just about their bleeding, but what are the other systemic things that change monthly for them, and then helping them figure out what do you want it to look like. And then we can kind of help tailor what we pick for them based on that. All right.
Okay, when I saw your tattoo, I was just so envious, and I didn't have time before we actually did the presentation, but I was thinking I should get the perimenopause equivalent because that would be such a good visual for everybody. It's on Women Living Better, and it is really instructive. I think if you, there is this one amazing piece of research where it was like 180 days of morning urine from a perimenopausal woman. And if you look at that chart and you, like me, have had a symptomatic perimenopause, you're like, exactly. And it just sort of normalizes this in the best way. So I'm going to start with just some definitions from this kind of later stage of our reproductive lifespan. So I'm going to start with the word menopause, which gets used to describe kind of everything related to our the shift to our non-reproductive years. But the true definition of menopause is it's one day, and it is the final day of your final menstrual period. The weird thing about this definition, though, is that it's a look-back definition. You don't know what that day was until you have not had another period for 12 months. And many people get to 11 months and have another period, and it resets the whole clock. Any time after that is called postmenopause, and in all the years leading up to that final menstrual period, you're in perimenopause. Now, there's another kind of general definition of perimenopause, and most people, and I think I'll ask most healthcare providers, think that perimenopause begins when you have irregular or skipped cycles or very noticeable changes. I think that is not true, based on my own experience and some research that I've done recently. And my belief is that these changes actually can begin in your late 30s and early 40s, and there's some data to suggest that there is a more precipitous decline in our follicle count starting around 38. And so there are some people who will never have many changes to their cycle or periods and no symptoms, and they will just reach that final menstrual period. And then there's others who have a really a more difficult time. The technical definition, it wasn't, I'll throw a couple of these things out there, but it wasn't until 2001, and then they kind of re-met in 2011, that an international group of clinicians and researchers got together and said, hey, we should have some common language around the way women proceed through this transition, because there was no way to harmonize research or understand where a woman was on this path. And so that definition says that perimenopause, or the menopause transition, begins when you have persistent 7-day changes to your menstrual cycle. So that would be if you were, had a kind of a average cycle of 28 days, you would have one of 35 or more, so it's getting longer. And you have to have 2 of those within 10 months to be considered perimenopausal or in the menopause transition. So as I said, that was certainly not my experience. And the little bit of research that I mentioned, I've started collaborating with these 2 fantastic women. One is an OBGYN who started a menopause clinic in Boston like 25, 30 years ago. So she has seen a lot of menopausal women. And the other is an epidemiologist, pioneer in women's health research. And the three things that have come out of our research is, one, that the symptom experience before this noticeable change in your cycles and periods is very similar for some of us to after. So it suggests that there is something happening much earlier than when you have a very long cycle or very irregular bleeding. The second is that the range of symptoms, I mean, the hallmark symptom of menopause is vasomotor symptoms, hot flashes, night sweats, vaginal dryness. Those are the two things that we know about, but and research is starting to bear out that it also includes brain fog, both in terms of recall, so you can't remember why you came into a room, somebody's name, a fact or figure you know. And then also, and I hear women describe it as sort of difficulty concentrating, more difficulty making decisions. So brain fog, disrupted sleep, absolutely mood. There's been a lot more research on depression in perimenopause. So if you've had a major depressive episode before, you're in a vulnerable window. But I happen to think, and again, based on my own experience and hearing from lots and lots of women, there is also a change in our stress response that makes us feel more anxious, like a new anxiety. I've heard so many people, and it was my experience, like I wasn't an anxious person, but all of a sudden it just sort of like it was a coping or a fragility that was new to me. So there's a lot more research to be done. Palpitation, I mean, the list goes on, and I think we will learn over time that there is much more connected to these hormonal fluctuations than we've ever kind of given credit to. And the last thing I'll say before we kind of get into the Q&A is that the other kind of general belief is that perimenopause is about a decline in estrogen. And the truth is that estrogen doesn't really decline until after your final menstrual period. And in fact, and again, I think this is linked to those of us that have kind of a more disruptive time in perimenopause, estrogen is actually rising higher than it's ever been and dropping. So it's a much more, I wish I had my tattoo because I could show it to you. I'm actually not going to get that tattoo, but it's cool. I don't know who could actually do that tattoo. So estrogen is more variable. I was about to use the word chaotic, but I will tell you that the amazing epidemiologist, statistician that I worked with said, could you please stop using the word chaotic because that feeds into women are not dependable and reliable. So I'm really trying, but when you look at it, it's variable, very fluctuating. I need a new word there. And at the same time, progesterone is declining because we're not ovulating as frequently. And so it's this time when our body, if you think about like high school biology and homeostasis, right? Our body is working to get back to that, but it's a big challenge. And I think that is why, for those of us that have sort of a disruptive time and lots of symptoms, that's behind it. So I'll stop. I could go on and on, but let's.
Yeah, thank you so much. I personally have already been like, oh, okay. I'm gonna ask you something later. But let's open up to all of you. Any questions? I think we also have some floating microphones. Sure, right here. Yeah, there's a microphone right here if you don't mind. Thanks.
I was wondering if you could talk about hormone replacement therapy and also how that relates to women with a tendency for blood clots and the research behind that. I've heard like, oh, it's been debunked. No, it's not. So I'd love to get your input.
We knew this would be first. So you should handle the medical thing about clots. I mean, what I'll just talk about generally. It's kind of helpful to understand the history of the Women's Health Initiative and kind of what went on there. And we literally could spend like a week discussing this, and there are so many different interpretations. Yeah. Oh. It is on. Oh, I just wasn't holding it up. So how does everybody know about the Women's Health Initiative? Is it worth? Okay. So the Women's Health Initiative was actually a prevention trial. People don't understand that, and the relevance is it was not to see whether menopausal hormone therapy lessened symptoms. It was to see whether it prevented specifically improved cardiac health, right?
Yeah. Right. So the framework, back in what, the 90s?
It started in I think 1998, and it was stopped in 2002.
And they took a bunch of women.
Yep.
They put them all on hormones, thinking it was going to help prevent heart attacks.
Yep.
That was their main outcome.
Yeah,
And then the problem is they had to stop the study early because they realized people were getting,
worse.
more heart attacks, strokes, blood clots, and cardiac events. So that's the framework.
Yeah.
And so that's where we get a lot of our data and our cautionary data from.
So at that point, everybody stopped using and prescribing. And then there was this whole generation of healthcare providers that were terrified to prescribe it, didn't know anything about it. And I think that, and now the pendulum is swinging such that, let me step back and say, the two things that hormone therapy are really good at solving are vasomotor symptoms, so hot flashes and night sweats, and I've heard many, many clinicians say it shuts that down. And the second is vaginal dryness, now called the SGSM, the genito syndrome of menopause. So it's, and then also for osteoporosis prevention. So those are the only three things it's indicated for. There are some observational studies, not randomized controlled trials, that suggest, and people I think are too liberally interpreting these, that it might be good for cognitive health, it might be good for heart health, but like I think the data doesn't exist, and so it's just, there's a data vacuum there too, is what I would say. But on the clot thing, you should handle the medical.
Yeah, I mean, I think, right, so as a clinician, you want to help your patient. You know, a person comes to me and they're saying, I'm not sleeping. I was never an anxious person, and all of a sudden I'm crying and I'm anxious and I can't sleep and I am like ready to pull my hair out, right? And I want to help them. But then there's also the part of me that's like, you don't want someone to get a blood clot and a stroke and then sue you too and die, right? So there's this balance, right? So I think the medical board, like ACOG, so the American College of OBGYNs, have said, okay, you want to help these people who have these vasomotor symptoms that can't sleep, that are really upending their life. Try to give them the lowest dose of a hormone replacement therapy that fixes the problems and use it for the shortest amount of time that helps them kind of transition through that time. And then eventually have to wean them off, right? And the hard part is, when do you wean them off? You know, a lot of people struggle with this for years. And then when you do wean them off, the symptoms come back. And so there's really not a great clear indication of when you should start, when you should stop, how much. The doses vary for each person. And, you know, I don't want to tell a person it's okay if you don't sleep. You know, like, I want to fix that. And so I think you have to kind of balance it for each person, right? So there is a clear risk between, you know, giving someone estrogen and getting a blood clot. That exists. And that's why people in pregnancy get blood clots more often than when they're non-pregnant. And so, you know, if someone has a blood clot history, I'm worried about giving them hormones, right? But the other thing to think about is there are other options that I try to lean into if I can avoid hormones. So if someone's not sleeping and they're getting these hot flashes and it's keeping them up at night, you can try other things. You can put them on, like, it sounds silly, but like a birth control patch, like, or not birth control patch, sorry, a patch of medicine that you usually think of for hypertension, so clonidine. It helps with hot flashes, and usually it's a low enough dose, especially if they also have maybe a little bit of underlying hypertension, it fixes that too, and their hot flashes go away, and they can sleep at night. Or if they have a little bit of anxiety that comes with the hot flashes, you put them in on like a medication, like an SSRI, like Lexapro or Prozac or something like that, and then it helps the anxiety and it helps the hot flashes. So you kind of can pick and choose, if they have other side effects, what you can put them on that helps kind of fix both. So if I can avoid putting on someone on a hormone replacement therapy, I try to, just because there are those other risks, and these other medications don't have that risk. And especially also for vaginal dryness, if that's their main symptom, you can use topical estrogen. You apply it vaginally, it fixes the problem, it's not absorbed systemically, it's not going to cause any of those blood clot risks, and they can use that indefinitely. They can use that for the next 50 years, you know? So that's...
Yeah, the other thing that I would add is, like, this is so individualized, and I think the really important thing is to find a provider that is like a good partner for you and knows your whole medical history, and just as Nisha said, kind of working through the pluses and minuses of all these different treatments. And then there are other people who it doesn't work for, like they feel terrible on hormones, and other people say it is a life changer. And so it really is, there is no like, it's good, it's bad. And so I think the pendulum has gone from it's really bad, and I think the truth is it's somewhere in the middle. It's really good for some people and their situation, but it's like not so good that everybody should be on there. And I've listened to a couple webinars recently where some of the older clinicians are like, oh my God, I feel like we're going back to, feminine forever, where it's like women need to be on this to be, sexy, and so they're kind of dismayed at this, how far the pendulum has swung. But I do think it is safer than people thought in 2002 for certain people, for certain indications, for some period of time. It's a terrible answer, and that's why I hate that question. But it's really an individual thing. And it's hard to find a healthcare provider that is comfortable and knows all these ins and outs. And so we can talk about that too.
So this is a related question. I was wondering about the topical estrogen. One thing my friends and I are talking about at this age is just no longer being interested in sex. And does the topical estrogen have any effect on that? If you're married and you're trying to remain interested in that aspect of life, is there something that helps with that?
So, my understanding is that it only helps if the dryness and the pain with sex is part of the problem. It doesn't help with libido, if that's what or like arousal.
Is there anything that helps with libido, like just wanting?
No, it does not. No, I'm saying it. But I think for some people, the dryness becomes a like, oh my gosh, or there's just outright pain with sex, or other irritation, and that it will help. The libido.
Right. So I think a lot of times there is a natural decline in libido after menopause. It's there. That being said, I definitely run into people who that isn't a factor, and I don't know what those other like protective factors are. However, if you have pain with intercourse, you're not going to want it. And there's like a cyclic feedback, right? If you're having pain, even if you have one painful experience, it makes you less interested, and then you shy away from it, and things like that. And so being a little more proactive about treating vaginal dryness up front so that you don't experience that pain, I think is very helpful for preventing that decline in libido. In terms of it's not enough hormones to change like your brain chemistry in the way that I think people would hope it would. There's like one FDA medication designed for women's libido, and it's dangerous.
I think it's scary.
It's designed for people who are premenopausal only, so also not the same target audience. And it can cause like liver failure, and I never write for it.
It's an injection, right?
Yeah,
it's an injection.
It sounds horrible. So the thought of giving yourself shots to have increased libido sounds not great. So. Yeah.
Thank you. Just one other totally different question.
Yeah.
I was wondering, so for my daughter, she doesn't want to have a period. Is there like an age that you think a child has to reach before you would think that would be, I don't know, I guess I want to say, are there any negative side effects to getting an IUD as a young teen if you don't want a period?
Yeah. We were just talking about that too, that we thought that might come up. So no, that you can totally do an IUD when they're younger. So in terms of cycle control with IUDs, there's kind of two main ones on the market now. There's the Mirena, which is the original, right? And that works for 8 years. It's got enough hormone that it helps prevent pregnancy, but it also helps usually for a lot of women stop their periods. So it's indicated from the FDA as a contraception, and it works for treatment of heavy periods. That's what it's indicated for. The same company now makes a smaller one, specifically designed for people who want, less hormone, or for teenagers. They market it as being for people who have never had babies, and they're smaller, and so they work really well for people who at least just want a lighter period. It may or may not totally stop your period, but both options are still safe in teenagers. None of them are going to cause infertility. They're not the same as the IUDs from, I think 40 years ago, when they had like a design flaw to them that caused higher rates of PID and infertility. So they are safe. They're fully reversible, and so then it's just a matter of, maybe based on a young person's size or what their goals are, we can kind of figure out which is a better option. And another thing to put out there, because inserting them can be uncomfortable, I have plenty of teenagers who would benefit from an IUD, and you can bring them to the OR, have them be sedated, place it. They don't have to be in pain, and then it lasts for 8 years, right? So it's a good option.
I'm just going to go back to vaginal dryness for a second. It's like my favorite topic. No, but one, it's not my favorite topic. But one thing that I learned as a layperson that I did not know that I think is just helpful to share is that vaginal dryness, vaginal atrophy gets worse. And so even if it's not with the goal of having sex or avoiding sex, it's worth treating it because, correct? Yeah. It just keeps getting worse. And then it's very hard to kind of get that.
It's hard to reverse it.
Yeah.
Elizabeth, sorry, I'm just curious, in following up with Nisha, your reply, what your thoughts are when you were talking about fertility awareness method, like knowing your body, right? And so for, how can we hold space for teenagers who don't want to have their periods, but then also from the perspective of knowing the power in knowing your body?
I mean, that is a great question, and I think that part of my talking before it was super individualistic because it was super my individual experience of loving that part of it. I love the idea of teenagers getting excited about knowing their bodies and tracking their cycles, and I think that is something that should also be celebrated more. And also, I really love teenagers knowing their bodies and being like, I do not want to get a period, and having the power to have providers who support them in that. And I think that we have for so long kind of dismissed this is a complicated history of reproductive coercion and who should get pregnant, who shouldn't get pregnant. There's been a long, complicated history of how we talk about birth control in teenagers and if teenagers are ready for hormones and things like that. And I think we do know now that it is safe and that it is, people can make their own decisions about their bodies, and I fully trust them to, I fully trust that if someone doesn't want to have a period, that is what's right for them. And I mean, there's a lot of, I hear a lot, I'm sure that this is something that you all do too, about people not wanting to do hormones because they want to be more natural or finding the lowest dose hormones to be more natural, or thinking that not getting their periods is unhealthy. Back to periods as a fifth vital sign, I think that is a really important thing to know, and people can be on hormonal birth control for a long time, not get any periods and not know underlying issues. That is absolutely something that can happen. That also, I'm just waiting for postpartum brain fog to hit. So if I stop talking at any point, please know why. But we know that it's very safe to not get periods for extended period of time. And I mean, people getting pregnant, having babies over and over again are not getting periods for extended periods of time. And that's, has its own risks separately, but that's safe too. I mean, my Irish Catholic grandmother who had 10 babies and didn't have periods for all those years of breastfeeding and being pregnant is basically what you're doing when you're using hormonal contraception. But yeah, thanks for asking.
So I just had a question about if hormone replacement therapy so much is based on this one study, are there other large-scale studies going on? And I was also interested in the medical school curriculum, is menopause and perimenopause, is that taught at all? If you're an OBGYN,
No.
do you get more of that? No. No, that's not the answer I want.
About that. Yeah.
It's unbelievable, but you know what? There's not that much to put into the curriculum, sadly. I mean, there's more and more, but again, this research gap it's staggering. So it wasn't until, I think, I wrote these down so I get them accurate, but it wasn't until 1990, so that the NIH established the Office of Women's Health Research, 1990. So all of these longitudinal studies that are starting to inform just kind of the natural course of what happens here started in the 90s. And only two of them, one of the amazing woman that I'm working with who's retired but has volunteered with me now for 4 years to do all the stats and run these studies, her study, which was called the Seattle Midlife Women's Study, and another study called the Penn Ovarian Aging Study, they were the only studies that started enrolling women at 35. Everybody else was so focused on the final menstrual period that most of that data starts with women at 45. So you don't see this, we don't have data for the earliest part or what the beginning looks like. And a lot of people say, I ask that question all the time, why isn't there another study? And people are like, there will never be another WHI. It was so expensive. It is so hard to measure hormones hormones are pulsatile, and they literally change minute to minute, hour to hour, unless you're doing the same exact time every day. And think about running a trial like that. It's really expensive and difficult, never mind for compliance of like midlife women. Who is gonna, so, it's a great question. And I don't know, do you think a trial's coming like that?
No, I also think it would be so hard to get that approved for the ethical implications that it might cause all these other negative, dangerous, deadly things. There's no one that's gonna take that on. So I think what then we are stuck with is the retrospective stuff. So people who take these medications, how are they doing? If they choose to take it and then you look back and how it changes your symptoms. I think we'll find hopefully more of those studies that come out. And then you asked about how much they teach you about this in med school, and we were joking about that before, but it's zero, right? So in med school, none. I think even when I was in residency, it was very much, when I was in the clinic, anecdotally learning about, hey, I have this patient who's come in and they have these problems. What do I do for them? And, whoever's precepting you, teaching you, like, oh, you could think about doing this option or that option, but none. No, there's really minimal. So a lot of it's trial and error.
Nursing is better, yeah.
I was going to say, so one thing
more.
in nurse midwifery programs now, there's a whole section in just the general women's health education portion on menopause. The whole point of the projects and work you do around it is to try to find research to put together bundles of recommendations and then to pull your hair out because there's not really good, consistent
I can
data.
help you. I'll help you.
No, literally, we're going to bring Nina next time. But I think that's also important, that if someone is telling you that they have the answer for everyone for menopause, if they're like, oh, well, I know that this is the right thing to do, that's not accurate, because there's constantly, goes back to knowing your body best and having a good relationship with your provider, because you're going to figure out together what works best for you, and there's no universal.
Nisha's a GYN, right? So if they're not getting the information, I think this should lie with our PCPs, right? This is not an illness. I even hesitate to use the word symptoms, but there should be another word, but nobody thinks of, more migraines and anxiety as anything other than a symptom, but it's not a disease. And so if GYNs aren't getting it, I do think, I've sent people now are always asking me who should I go see? And I think a lot of the really good studies have come out of the nursing literature. In fact, my research, the fantastic woman that I work with comes out of the nursing world. And also nurse midwives are very good providers at this time as well.
Well, I think also,
and you got to think too, typically, I'm just going to make general statements here, a lot of the people going into the nursing fields that are doing this research are women. Mm-hmm. A lot of the people going into midwifery are women, right? A lot of the people going into medical school in general, it's actually now still more women than men, but that was not the case for a very long time. And there's just a different focus when it's primarily, a split gender field versus not.
And also I think this is now getting into kind of a different topic, but the nursing and midwifery model of care too is very much just acknowledging normal life events and normal transitions.
A lot more holistic, whole body experience, and not dismissing the symptoms that are coming with you, which I think a lot of, and unfortunately I hear it again and again, people go to their providers, they're saying, hey, I'm having this symptom or that symptom, and it gets not dismissed, but kind of, they're focusing more on their hypertension and their whatever else. And they're we got to fix your diabetes, which are all very important. But then they don't schedule a second follow-up visit to bring someone back to talk to them about the fact that they're getting night sweats, And that might be contributing also to their quality of life.
I think the dismissal is real, certainly in perimenopause, and certainly if you're not having, that was my story. If you're not having irregular periods, you're too young, or this can't be perimenopause because you're still getting a period every month. The thing I will say, so I was not a tracker. I was I wish I had known you. I probably would have had the IUD much earlier, but I just pretended to ignore my period. But in perimenopause, I've become an obsessive tracker. and it's so helpful and interesting to for me to see. So if you are actually tracking what is typical for most people and there's no normal, is that your cycles will start shortening, but you have to, and all of my data is on the Women Living Better website if you want to see it for years and years, but the trend line is down. So your cycle, you start getting your periods closer together, and if that is happening, that is a sign that you can be sure that your hormone levels are changing and you are in perimenopause. So, and so they're going to get shorter, 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 and then they start spreading out and getting longer, longer, longer right before, as you get closer to the final menstrual period. So if you, don't need to shut them down for, mood reasons or other things, it can be a very helpful sign in perimenopause as well.
So I think maybe we have time for maybe one or two more questions.
I wanted to sort of, I guess, piggyback a little bit on what you said, and it's more about women's health in general. And for years you hear we're judged by men's standards, or people don't pay attention to how there are nuances in women's health. And I think when you're younger and you're generally in good health, you kind of ignore that. You're it doesn't portray to me. But as I've gotten older, I've found that indeed it is true that sometimes you feel as a woman, and there are lots of stories in the media now, your symptoms are sort of ignored, or they don't, even with a good PCP, that they're sort of, like you said, they kind of throw. Do you see there are actually shifts coming, or because we're not doing these studies for women and women in midlife, that we're not likely to see a change in kind of really looking at this?
No, I think actually change is coming. There won't be another enormous study about hormone therapy, but there are lots of other studies now looking at the linkage between hormones and symptoms. I mean, there's actually a lot of really exciting research going on, the study of women's health across the nation. I mean, so I didn't mean to paint such a, dire picture. The dire picture is about head-to-head hormone therapy. That will be a tricky study to do. But I also think there are more providers that are there's the North American Menopause Society has a program, and more. It's getting better, and there are some startup companies that are filling this gap. I hope it goes back to PCPs being educated, but I think if your provider isn't listening, look for another provider, because if it's happening to you, it's valid and it's normal, and you should be able to have a provider that's going to help you if it's kind of getting in the way.
Yeah, I'm pretty sassy with him, so it's
good.
It's
good. Yeah,
and he covers most of our family, so we get people to listen. But I do find that every once in a while, and I've heard other people, just my peers, talking about how they feel that they're they get sidelined. It's they complain about things, and people are oh, those are just normal symptoms of women your age.
Yep.
And you're but it actually could be, something else. And if the blood work isn't showing it, and it's maybe not just menopause, it's maybe just across the board. But if,
I think people are asking more, right, which is good, right? I think people are much more savvy about saying, hey, this is a problem, I'm going to see someone about it, than I think people were in the past. And I think people advocate for themselves more nowadays and feel more comfortable asking about their health and asking about the reproductive life and what their choices are. And there's ads, there's more websites that people look up. So people come to me saying, I think I have endometriosis. And I'm like, oh, okay. So a lot of it's, education, finding out, is that true or not? What? But I think people come to me more prepared now than even 10 years ago, with questions in mind about what they're thinking about, what they're facing. And so I think my hope is that things will get better and that people advocate for more and more. I think, depending on which issue it's about, if it's about menopause, I think the problem is I don't have a lot of the answers for people when they come to me. When it's about other stuff, sure, there's more research done.
One last question.
This is sort of a piggyback onto that question. I was reading an article in Forbes that there's a $600 billion market in menopause research and just in that space. But it seems like it's entrepreneurs and small companies that are doing the research and not pharmaceutical companies really. And I'm just wondering if you had any insight into why. Is it we were talking earlier about how Viagra and all these things for erectile dysfunction are such huge money makers, and there's nothing out there except this dangerous drug for female libido, and but there's companies I think one researching electrodes for vaginal dryness or something. So just why the pharmaceutical companies aren't taking a bigger interest in this, if you have any insight into that.
Yeah, I mean, I think there are definitely a lot of other things on the market and things being tested. There's a lot of like laser rejuvenation and a lot of focus on products that you can order online for, there are celebrities that tout different options and treatments. And I think the problem is, you're right, there's not these well-studied methods out there. So there are plenty of people coming and saying, you can do this like, vaginal treatment or a topical medication or something that might help with libido or that might help with vaginal dryness. I think the problem is not all of them, they do their own internal research. The company themselves does the research on their product and they say, yeah, this works. The problem is they haven't been studied on a wide scale. I don't know that they work. Not all of them might be safe. Some of them, and I think sometimes people will like, that sounds bad, but sometimes I think there are companies who want to create a market for their product, right? And so they'll say things that are normal, like normal vaginal health, and they'll say, well, we need to help you rejuvenate it. And I think there's a slippery slope about how to approach that.
I just want to say, I feel like I would be a bad nurse midwifery student if I didn't like also jump in and just be like, a lot of things, like the massive markets for fixing a lot of issues, I really think gets away from the idea that a lot of things are just normal and are okay, and knowing your body best and knowing how to treat your body is the most important thing, and that a lot of the markets are tapping into stigma. Yeah, exactly.
There's a lot of people coming into the office asking for like cosmetic fixes for their vagina, which are,
I mean,
not needed.
Yeah. And like issues that are created in order to feed into
market. Yeah.
Exactly. And I think one of the most important things that we can do for the perimenopause period, I mean, for periods, for libido issues, for, like, is literally just talking about it. I mean, I think that is the biggest, like, not even with healthcare providers, but like with each other. I think that's super important.
Yeah, and not to be cheesy, but I think that that's a great message to take away from this panel of like, ask the questions, turn to the person next to you and the people around you, and bring up these, these feelings, these things that you're going through, and find providers that you trust and that you connect with. I'm trying to catalog all these nuggets of takeaways, but thank you so much. And I think also for me, I hope that all of you know that you are pattern makers. So like, I hope that you take whatever small nugget you took from here and take it outside of this room, right? Whether in a breakout session or later on or at home, and just like continue to ask the questions and be curious and celebrate yourself. Thank you.
Thank you.